Hello, hello, hello. Well, it's 10 question Thursday. I missed 10 question Tuesday. There's a lot going on, so here I am Thursday. I still have 10 questions for today. These are handwritten this time, so I don't know if you can see backwards, but these are my questions. And so I am going to introduce myself. I'm Cheryl. I'm a registered nurse. I have 20 years of experience in the surgical ICU, specifically cardiovascular surgical ICU. I work at a large hospital in Washington, D.C., and I do this because I want to help other nurses kind of acclimate to that new environment of the ICU. So here we go. We're going to just do 10 questions. You can replay the video. The questions, some of them I got from the Pass the CCRN book, and then there's an app out there that you can use, Pocket Prep, to prepare for the CCRN. So here it goes. Number 1, all of the following are common signs and symptoms of renal failure or acute renal failure, which is acronymed ARF, except A, bradycardia, B, oliguria, C, dry mucous membranes, D, nausea and vomiting. The answer is bradycardia. Signs and symptoms of acute renal failure include oliguria of 400 milliliters or less per day, or anuria of 100 milliliters or less per day. Tachycardia, hypotension that's prerenal, hypertension that's intrarenal, flat neck veins, which is a prerenal condition, distended neck veins, which is intrarenal condition, dry mucous membranes, cool, dry or clammy skin, lethargy, rapid respiration, nausea, vomiting, and confusion. So those are the signs of acute renal failure. All right, next question. The acronym CPAP stands for, we usually say CPAP. The acronym CPAP stands for Continuous Positive Airway Protection, A. B, Continuous Positive Airway Patient, C, Continuous Airway Pain, and D, Continuous Positive Airway Pressure. Well, the answer is D, Continuous Positive Airway Pressure. This is a form of positive airway pressure ventilation which applies mild air pressure on a continuous basis to keep the airways continuously open in patients who are able to breathe spontaneously on their own. Welcome. The next question is, a normal EF or ejection fraction is usually over what? You have 60%, 70%, 50%, or 80%. The answer is 60%. The EF is defined as how much blood is pumped with each contraction. You're welcome. In relation to the volume of available blood at the end of diastole. Atrial contraction adds about 15% to 20% more to the total ventricular volume. So a normal EF should be over 60%. Okay. Next question. The critical care nurse is caring for a patient with a diagnosis of cardiogenic shock. Which hemodynamic parameter is aligned with this diagnosis? The first option, A, is heart rate 82 beats per minute. B, pulmonary artery wedge pressure of 5. Left atrial pressure of 15. Cardiac output 8.9 liters per minute. The answer to that question is left atrial pressure, abbreviated LAP. The normal value for LAP is 6 to 12. An elevated pressure of 15 best aligns with the diagnosis of cardiogenic shock. In cardiogenic shock, the heart ceases to function effectively as a pump, resulting in a decrease in the stroke volume and the cardiac output. This leads to a decrease in blood pressure and tissue perfusion. The inadequate emptying of the ventricle increases the left atrial pressure, and when that increases, pulmonary venous pressure increases as well. That leads to elevated pulmonary capillary pressure and pulmonary edema. So everything kind of backs up into the lungs. Okay. The fifth question. I hope this is helpful for you. The dyspnea that accompanies bacterial pneumonia, a common acute respiratory infection, is primarily caused by A, inflammation within the pulmonary tissue, B, decreased cardiac output, C, inadequate peripheral circulation, and D, pleural effusion. Which one do you think it is? I think it is A. So inflammation within the pulmonary tissue. A patient with pneumonia has less lung surface available. Yay. Yay. Got that right. You know, I don't know how to do all of these gestures on here yet, so yay. Thumbs up for that. Okay, a patient with pneumonia has less lung surface available for the diffusion of gases because of the inflammatory pulmonary response that creates lung exudate, resulting in reduced oxygenation of the blood and impaired ventilation distribution. This thus decreasing lung compliance. This inflammatory response also causes an increased work of breathing and dyspnea. All right, let's go to number 6. When considering weaning a patient from a ventilator, which of the following criteria indicates that the patient is not ready to be weaned? A, minute ventilation 5 liters. B, respiratory rate 26. C, FiO2 of 0.60 or 60%. And D, PaO2 or FiO2 ratio greater than 200. So when you're weaning a patient, which of the following criteria indicates the patient is not ready to be weaned? The answer is C. Yes. Weaning parameters include the following. FiO2 has to be less than 50%, spontaneous respiratory rate less than 30%, spontaneous tidal volume 5 milliliters per kg, and vital capacity 10 milliliters per kg or more. They ideally look for 15 milliliters per kg. Minute ventilation less than 10 liters. Negative inspiratory pressure less than 25 to minus 25 to 30. And then your PaO2 FiO2 ratio greater than 200. So there's your answer. Great job. Okay, next question. An ICU patient is experiencing low cardiac output syndrome Which of the following vasopressors is indicated when the desired effect is vasoconstriction without tachycardia? A. Dopamine. B. Phenylephrine. C. Norepinephrine. Or D. Epinephrine. Hello. Welcome. So I'll read that question again. An ICU patient is experiencing low cardiac output syndrome. Which of the following vasopressors is indicated when the desired effect is vasoconstriction without tachycardia? Is it dopamine? Is it phenylephrine? Is it norepinephrine or epinephrine? You know, I'm on this little camera, and so I wear glasses. I have to like get close to see, you know, the names and stuff. So my apologies. I'll put my contacts in next time. Okay. So, I got distracted now. Okay, phenylephrine is the answer. Okay, epinephrine, norepinephrine, and dopamine all have a combination of alpha or beta stimulation effects, both producing vasoconstriction and increased cardiac stimulation, so inotropic and chronotropic effects. This makes the heart beat stronger and faster. Phenylephrine is the only one that is an alpha stimulant, so that medication will have a less effect on the heart rate, so no tachycardia. Okay, next question. Which of the following is the most definitive test for the diagnosis of aortic dissection? Thank you for that. So I'm distracted. I'm trying to read comments and read this too. All right, the question is, which of the following is the most definitive test for the diagnosis of aortic dissection? Aortography, echocardiogram, MRI or CT, or chest x-ray? Can anybody guess? Yeah. I'll give you 15 seconds to think about it. So the options are A, aortography, B, echocardiogram, C, MRI or CT, and D, chest x-ray. Oh, maybe. All of them will give you an idea, but the most definitive one is the MRI or CT. Of course, the MRI is more detailed. The CT is a lot more quicker way to just scan someone and get an idea about the dissection. So the answer officially is an MRI scan or CT scan is the most definitive test for the diagnosis of aortic dissection. An MRI determines the size of the aorta, the size of the aneurysm, the extent of the dissection, the involvement of the additional branches of the lumen diameter, as well as the thickness. So it gives a lot more detail. In the place that I work, we typically do a CT. MRIs take a lot longer because they're so detailed. And if somebody's having a symptom of dissection or having an aortic dissection, you don't want to wait for a 3-hour MRI to find out. You just do a 5-minute CT instead. Okay, our second to last question is, what is the most severe form of heart failure? Right-sided heart failure, A. B, cardiogenic shock. C, left-sided heart failure. D is acute heart failure. QC MSN 11. All right. Left-sided heart failure is dangerous. All of them are dangerous. But the answer is cardiogenic shock. Cardiogenic shock is a life-threatening condition, and it requires like emergency management. So in cardiogenic shock, the heart is unable to pump enough blood to meet the oxygen demand and the metabolic needs of the body, resulting in decrease in stroke volume and cardiac output. The other forms of heart failure are not as severe. So your right-sided heart failure is not as severe. Now you can have cardiogenic shock and require like a device, like a balloon pump or LVAD. And I had a patient the other day who emergently needed, because he was in cardiogenic shock, he emergently needed LVAD, which was placed. It was like a HeartMate 3. And then during the procedure, they couldn't get him off of the bypass. And so it was, yeah, that was a tricky one. Yeah, for sure. So they couldn't get him off the bypass. So what they did was they put in a right ventricular, a right VAD, or ventricular assist device. So that was like a centromag. So this person had bivads, they call them. So, and then over time, they adjusted his pressors and used a lot of epinephrine, milrinone, and they adjusted those down. They adjusted the speeds down, and then they took off the right one eventually. This man had it for about a week. So definitely cardiogenic shock is more acute. Okay, next and our last question for today is, how is cardiac index calculated? This might be a little difficult. Like, let me read through the answers. All right, A, dividing the cardiac output by the patient's BSA. Dividing the cardiac output by the patient's weight. Dividing the cardiac output by the patient's pulmonary capillary wedge pressure, or dividing the cardiac output by the patient's MAP. So how do you calculate the cardiac index? A, dividing the cardiac output by the patient's BSA. B is dividing the cardiac output by the patient's weight. C, dividing the cardiac output by the patient's pulmonary capillary wedge pressure. And D, dividing the cardiac output by the patient's MAP. Any guesses? Yay. It's always the BSA, right? Never had to calculate it. Those monitors are very smart. They do all the calculation for you. So I'm happy with that. But cardiac index is a hemodynamic parameter that relates the cardiac output from the left ventricle in 1 minute to body surface area, thus relating heart performance to the size of the individual. The unit of measurement is liters per minute per square meter. And then the calculation is cardiac output divided by BSA divided by 1,000. It gives you the cardiac index. And normal cardiac index is 2.5 to 4.3. Yeah, I know. If we were to calculate all of these, spend a lot of time and calculate them, we probably would remember them, but they will take a lot of time to do. And then the patient may, not get treated as quickly. So I definitely appreciate the technology. I wasn't a student in math. I like geometry. I did much better in geometry than calculus and those other things. So I'm glad for computers. I'm a little techie, so I'm glad for that. Any questions that you have? Yeah, there's CCRN questions. If you download the app Pocket Prep, that app can give you, it has like 400 questions in there. You can select cardiac questions or multi-system questions or respiratory or whatever psychiatric questions, and then create tests. And so the way I prepared for that was I would do about maybe like 20 questions every day. And when I had like more time off, I would do a lot more, like maybe 50. And then I would go over, it allows you to flag the questions that you didn't do well on, or ones that you want to learn more about. So you can always go back to them and review them. And it's really good with the explanation or the rationale by why, like I picked a lot of wrong answers, and it explained to me why that answer was right. So I found it very easy to use and to understand, versus going through a big thick book and flipping around trying to find stuff. Oh, you're welcome. You're welcome. I've been only certified lately. Like the last certification I did was a year ago. I don't know why it took me so long. I think the first time I went, I did that CCRN was maybe about 4 years ago. And when I went in, I failed, and I just gave up. And I just said, you know what, let me just go and do it again. I've been in this long enough. I should be able to, to study and pass it. And then sometimes these tests they're academically written and not real life, real world written sometimes. So they can be tricky. I'm glad you enjoyed the refresher. So next time I will do 10 more questions. Will be on Tuesday. I like that. I like that very much. I not a fail. You tried and passed when you returned. Hello. Look, I have to lift I'm nearsighted, so I see better with my glasses off. The Paul Day joined. Hi. Oh, we just went through 10 questions, and I used the Pocket Prep app. I'm not being paid for any of this, by the way. The Pocket Prep app to source my questions this time. I found it was easy to use and get refreshed on. Even if after you pass your CCRN or like the CSC exam, you can still use it to refresh your brain, Well, guys, I appreciate you joining me for this. I will post this video on the IG, on my IG, so that you can go over the questions that I just went over. All right, so see you next time. Thank you. Have a great evening. See you Tuesday at 7. Yes, sorry. Sorry. But I'm going to post what I just went over. So in the next like 5-10 minutes, you can look in my on the video, the IGTV videos, and it will be there. So you're not going to miss anything. I always post them afterwards. But it's fun to like go through it and try to, figure out what the answer is. And maybe one of these days I'm going to do a giveaway. So any suggestions for a giveaway, you can DM me or something, or email me. All right. All right, guys. See you on Tuesday at 7. Bye now.